Good morning. May I request Dr. Alexander Thomas, the President of the Association of Healthcare Providers India, to welcome the Chairman. Kindly hand over a bouquet, Dr. Alex, please, on our behalf. Ladies and gentlemen, you are listening to the voice of the Master of Ceremonies of this morning's function. It's my pleasure to extend a warm welcome to all the participants to this morning's inaugural function, being jointly organized by the Indian Space Research Organization, the Association of Healthcare Providers India, the Society for Emergency Medicine in India, and the various participating hospitals to this inaugural function. May I have the pleasure of requesting Shri S Somanath, Chairman, ISRO, and Secretary, Department of Space, to kindly adorn the dais, please. Dr. Shri S Somanath. To be followed by Dr. Brinda V, Director, DSRQ, ISRO Headquarters, and of course, Dr. Alexander Thomas, President, Association of Healthcare Providers, India. It's our privilege to formally welcome them with saplings. And may I request Dr. Reshma to present a sapling to our chairman, please. Dr. Reshma. To be followed by Miss Vaishnavi, who will be presenting sapling to Dr. Brinda. And Ms. Aishwarya to Dr. Alexander Thomas. While thanking the dignitaries, I thought it would be most appropriate to start with a wonderful quotation by George W. Bush. Quote, "Mankind is drawn to the heavens for the same reason we were once drawn into unknown lands and across the open sea. We choose to explore space because doing so improves our lives and lifts our national spirit. Let us continue to journey." Unquote. In the spirit of this statement of improving the lives of the citizens of this planet, the ISRO, AHPI, and SEMI have joined hands to come up with the quality upgradation enabled through space technology. And it is a very auspicious occasion. And I have the pleasure of requesting the invocation, please. Can we have the invocation? I request the participants to be on the feet as the invocation is being rendered. Thank you. Having invoked the blessings of the divine, may I now request Dr. Alexander Thomas to formally welcome the chairman and the other dignitaries, and also provide an introduction into today's meeting program.
Thank you, VC, and good afternoon to all of you. Chairman, sir, members of the staff of ISRO, and my colleagues from SEMI and AHPI. A warm welcome to all of you, and it's so great to see all of you here, especially after the 2 years of COVID. 2016 actually seems a long time ago. This was the year that Dr. Kasturi Rangan, all of you know him, the former chairman of ISRO, member of parliament, chairman of NEP. We were having a conversation on the sidelines of the Karnataka Knowledge Commission. He was a chairman and I was a member. I had the privilege of working with this great man. He's my mentor in various areas with a health policy for the government of Karnataka. For the national education policy, we gave a lot of inputs from the medical side of it, which have been implemented. And with setting up of a national think tank on health at the National Law School, University of India. So coming back to this conversation, I was sharing with him the error rate. He was asking me what are the errors in the hospital healthcare sector, and he was expecting me to say 0% or 1%. I think all of us here, the healthcare people, know it, but to my colleagues in ISRO, the healthcare, the error rate in the health sector in the developed world, not in India, is about 8 to 10%. Unbelievable, but true. So naturally, being a scientist that he was actually shocked. He said, we send our rockets from ISRO to space, the aerospace industry 0%, and you're dealing with lives, and it's such a high incidence of errors. So that's how the story of collaboration between AHPI and ISRO started. So I met with Kiran Kumar sir, he was a chairman at that time, and we got started. So looking at the various areas in the hospital, the emergency medicine, and my colleagues in ISRO, the emergency medicine is the entry point of the hospital. All the cases come in, usually it's a situation of chaos. People coming in, unfortunately, people dying, a lot of chaos. And we thought that there were two areas we identified. One was the critical care areas, the intensive cares, and the accident and emergency. Fortunately for us, we have this organization called SEMI, and it's a young specialty. Accident and emergency is a young specialty, and all the members of SEMI are young and enthusiastic. They were also keen to join, and I must say that my experience, our experience of AHPI with SEMI has been absolutely great. They have played a very crucial role in this project, and it's, I think, one of the, we had tie-ups, other associations, but they didn't follow up, and I'm very glad to say that SEMI has taken this forward. So after we had after that first meeting, we had multiple meetings, I think over a year. Both the ISRO specialists and our SEMI specialists came up, and then we came out with this health quest document, which is in your hands now. This, in essence, are recommendations of how to incorporate space industry safety practices into medicine. At this time, I think it's only appropriate that I acknowledge many of those who were involved in the Health Quest document at the time. All the ISRO officials, I won't mention names because that will come later. Many of them who helped and guided us. The other partners at that time is Planet Aerospace. They're a spin-off of ISRO. We had some very enthusiastic and wise advisors from there. Of course, SEMI was a core of this. We had the National Accreditation Board of Hospitals. They were also part of it, and so was a consortium of accredited healthcare organizations. They all helped in getting out this document, and I just want to remember them and appreciate their help. So based on this document, Health Quest, a pilot study was done. It's all very well to come out with a theoretical document. I think all of us are doers, and we did a pilot study, one in Chennai and one in Bangalore. And that showed a significant improvement in morbidity and mortality. And hence it was decided that we need to take this forward and do at a national level. We are very, very grateful to Shivan sir. He was the one who enabled us to, to start this study. Unfortunately, COVID came in between and literally stole 2 years of our time. Hopefully that is, I think, behind us now. So for this particular project that we are doing all over with 11 hospitals all over the country, I must mention that this group met every Monday. So Monday, 3 o'clock was meant for ISRO research over the last 1.5 years. And we've probably had close to 100 meetings. And I see a lot of them sitting here. The good thing about it is a few of us, I qualify to be called a senior citizen, a couple of us in that committee, but most of the other members of that committee of this group who's come up with this were young and enthusiastic, very dependable, very proactive, and it's been a pleasure actually to interact with them over these years, and we've had some experts from well-known experts also helping us. Today, as was mentioned, we have representatives from 11 hospitals all over the country. These are the site champions in their respective hospitals, and we really appreciate their involvement. I think the very fact that they are all here representing their hospitals indicates the passion and the commitment they have. The finding of this pre-intervention phase, what we did, will be presented and also with the way forward. We are hoping that this study would be completed by November 15th. And we can again present the final study to this group first. Incidentally, I think this is the first time that a study has been done between space and health with regards to safety. I mean, a lot of space innovations which have come to medicine, but with regard to safety, I think this is the first study which has been globally conducted. We have been discussing collaborations with ISRO for the last few years. We had gone into great detail, we had got experts down, but then for a variety of reasons, including the pandemic, we were not able to take it forward. But I feel now is the time is right now to restart our discussions and take forward whatever our thoughts are. Chairman had already suggested that ISRO and healthcare professionals interact and see where we can work together and collaborate. ISRO experts can showcase their capabilities, and AHPI, through its large network, can get representative experts and associations from all over the country to interact and also explore areas of common interest. This, we hope, that will start happening over the next couple of months. However, there are a couple of projects which we can start immediately, and I would like to place it before the chairman for his consideration. We have today with us emergency physicians from all over the country. And I think it may be an appropriate time for us to think of geomapping all the accident and emergency centers all over the country. We had considerable discussion over this, so I think we can pick up from where we stopped. And the discussions with chairman was that ISRO has got a huge amount of data, and this will be something that we can take off immediately. We could probably do it in a phased manner, start off in Karnataka or any other state which we think is fit. This will, I mean, for those who are not very familiar with this, what will it give us? It would give valuable information to the patients, accurate information as to the type of services available in a particular center, the level of care available. There are different levels of care available in different hospitals. It tell you what level of care is available, who are the specialists available, and very importantly, providing service during the golden hour. I think we lose many lives because of lack of attention, of the appropriate attention at that particular time, the first hour. And many a time, a patient who is sick goes to a hospital, the facilities are not there, he goes to another hospital. So this would be one area where we can focus on. And also, the availability of ambulances. It's Murphy's Law, when you need an ambulance, you'll never get an ambulance. So we hope that this will also, geotagging will help us know where these services are available. Later, I think we could carry on this and take this forward along and do this with availability, geotagging of intensive care units. I remember my time when I was in Baptist Hospital. Our ICUs were invariably full, and we used to get very sick patients coming into the ICUs. And I remember many times we had to actually send the patient with a doctor and a nurse all over town, and many times the patient has come back because there's no bed. So this is a service, I think, that we can look at. this will be immensely beneficial. This whole process of geotagging will be intensely beneficial and certainly save lives and help improve the quality of care that we give to our patients in our country. Another collaboration, I think most of you have, the healthcare people here know that health and climate change is some area that we need to collaborate in. If you look at the greatest health threat to the country, to the globe, today it is climate change. And I always say that the greatest challenge among healthcare people is that our lack of awareness. 7 or 8 years ago, if you had asked me about climate change, I would have been able to tell you nothing. We are blissfully unaware, sitting in our own silos. Fortunately, Srinath Reddy from PHFI had asked me to work with him in climate change, and we realized how important it is and how little we know. So this is the reason that we have actually come out with a book on climate change and health. This is available as a free download, and I think it's important that we sensitize our medical community on the health and climate change. Also, I think very few of us know that if the health sector is put together, we actually contribute 5% of the environmental pollution. So there are lots of things that we can do. And generally, doctors and healthcare professionals are thought leaders. I think we can educate the company on this area. We value this partnership with ISRO very, very much. I think it's been a very good partnership. We've both been very persistent with each other. The fact that we have been at it now, it's almost 5 years. We value this partnership and hope that we will be able to work together and impact healthcare positively in our country, making quality healthcare affordable and accessible to all our citizens. That is a dream of our Prime Minister, and we also share in that dream. I think I'd like to end by saying that today let us dream to make India the Mecca of healthcare. Now, I've got about 4 to 5 decades of health experience behind me, so I'm not just not shooting my mouth. I know India has the resources, we have the capabilities to be the healthcare capital of the globe. We have huge resources. All our people are outside. I mean, if you look at in the country itself, I think if only need to work together and have a will, and I'm sure we can fulfill that dream. Thank you all once again. Welcome to you all once again, and hope you have a good time. Thank you.
Thank you, Dr. Alex. And with that, we move on to the lighting of the lamp. Now, as I'm about to request the dignitaries of the dais to formally inaugurate this by lighting the lamp, it's also our privilege to request certain other experts who have been connected with this quest study. May I request the following to kindly join the dignitaries on the dais. Dr. N Venkatesh, President, Society for Emergency Medicine India, and the Head of Emergency, Apollo Hospitals, Bangalore. Dr. S Srinath Kumar, Past President of SEMI and Group Emergency Head, Narayana Health. Dr. R. Jitendra, Data Scientist and Research Expert. Dr. G. Vigneshwaran, Consultant, Clinical Research, Narayana Health. And Dr. Mansoor Sheikh, Emergency Consultant, Mehta's Hospital, Chennai. O fire divine, thou visible symbol of the Supreme Being, who knowest all our virtue and failings, uphold our good and burn up our sin. We offer our prayer to you again and again. Lead us by the fair path beyond pleasure and pain to the abode of the supreme good that is divine. Thank you, the dignitaries and the experts. Dr. Alex, in his introductory speech, did make a mention about climate change and the health. I must mention that the Association of Healthcare Providers India, experts like Dr. Alex. With his vast experience, they have probably come out with the first book in the country on climate change and the role of the health sector and how health sector would lead in combating climate change. May I request Dr. Alexander Thomas to hand over a set of these books to our chairman to place them in the libraries of the corresponding units of ISRO so that he would benefit from it. Thank you, Dr. Alex. In fact, the inaugural address for this program would have been delivered by Dr. Devi Shetty, but for his preoccupation, it's something very, very important. That's why he has sent a video message wishing us all the best on this momentous occasion. May we have the video message, please?
Hi, my name is Dr. Devi Shetty from Narayana Health, Bengaluru. AHPI is trying to tie up with various industries unrelated to healthcare to guide us in reducing the medical errors in healthcare. As we all know, aviation industry is one of the safest industries on the planet. Indian Space Research Organization, which is recognized as one of the premier research organizations in space technology, is known and famous for its safety practices. The interaction between AHPI and ISRO happened with a casual interaction between Dr. Alex from AHPI and Dr. Kasturirangan from Indian Space Research Organization. The result of this interaction is the launching of Quest with the single motto of making healthcare safer for the patients by reducing medical error. Emergency rooms are one of the common places because of the chaotic situation which occurs when large number of accident victims arrive at the same time. Is the ideal place to put in the protocol processes with the help of ISRO to reduce the human error. And we are very pleased to present our experience of having launched this process and protocol across 11 hospitals emergency room. We are extremely grateful to all of you for the great cooperation, and I'm sure in the future, in the near future, all the best practices which emerge from this interaction between ISRO and hospitals will be available across the country and perhaps across the world to make healthcare safer for the patient. Thank you so much.
We would like to thank Dr. Devi Shetty, and with that we move on to the next item in the program, requesting Dr. Brinda V, the Directorate of Safety, Reliability and Quality, ISRO Headquarters, to render the felicitation, please.
Respected Chairman ISRO, Scientific Secretary ISRO, Dr. Devi Shetty, Chairman Narayana Health, Bengaluru in his absentia, Dr. Alex Thomas, President AHPI, Dr. N Venkatesh, President ACMI, Dr. S Srinath Kumar, Head Narayana Health, Dr. V.C. Shanmuganandan, Advisor AHPI, and all the eminent doctors from across the country who have assembled here to be with us today. A very good morning to you all. Let me first place my sincere gratitude to Chairman ISRO Secretary DOS for encouraging us and supporting us and continuously guiding us to make this program happen here today. Coming to the topic of today, I feel there is a striking similarity between space and medical field. In both, mistakes are unpardonable. So safety, quality, and systems and procedures should be of highest standards possible in both our fields. It is heartening to note that we are shaking hands to work together for a noble cause of highest standard and quality to serve the nation and mankind. It's really gratifying feeling for me to be here today among all of you. Doctors are like gods to all of us. And I want to sincerely thank all of you for taking care of us and ensuring that we are all happy and healthy. We often discuss here about the positive impact of the space technology in society in various sectors, especially in healthcare. And by way of the space technology spin-offs resulting in cost-effective medical equipment or human support systems and so on. But I think this spin-off is quite different. I wish today's event a grand success, the fruits of which will definitely yield much more positive results for the benefit of everyone in our nation. We, the quality team of ISRO, extend a wholehearted quality support to the HealthQuest program in this noble endeavor. Best wishes and thanks to all the speakers for taking time and effort to share your experiences with others. Thank you very much.
Thank you, Dr. Brinda. With that, we move on to the presentation of the pre-intervention data of the quest study by Dr. Jitendra R.
Chairman ISRO, sir, and Secretary DOS, Shri Somanath, National President AHPI, Dr. Alex Thomas, Director, Dr. Brinda, dignitaries on the dais and off the dais. It's indeed a pleasure and an honor to present the results of the preliminary analysis conducted at the end of the pre-intervention stage. I take this opportunity to congratulate and thank all the sites who have successfully accomplished this landmark. The credit goes to you. And what we are presenting today is your hard work. Next, please. The Quest KPIs can be broadly classified into 9 time-based KPIs and 4 incident reporting KPIs, key performance indicators. Let's look at the time-based KPIs. The 9 time-based KPIs are door to the triage time. That is the time at which the patient actually kind of comes into the particular emergency department till the time the triage is actually done by the nurse. The second is door to doctor time. Third, door to needle time in stroke thrombolysis. And door to mechanical thrombolysis is the 4th. Door to pain assessment is the 5th KPI. The 6th is pain assessment to reassessment time. The 7th would be door to lab investigation ordering time. The 8th would be time from ordering investigations to the first review of investigation by the doctor. And the last is time to discharge from arrival. So these are the 9 key time-based KPIs that we have concentrated on. The next set of KPIs would be the incident reporting KPIs, which deals with safety, like for example, the patient falls, medication error, failed intubation rate, the infections, the hand hygiene compliance, mortality, the nurse to patient ratio. And I would be presenting the data pertaining to the time-based KPIs, and my subsequent speaker, Dr. Vigneshwaran, will be touching upon the incident-based KPIs. Kindly bear with me, this will be the only slide where you get to see a lot of numbers. I promise you that's the only slide. Now this slide is being projected to give you a glimpse of the back-end calculations and some of the thumb rules that we have actually kind of put in place. We have the name of the site there. The next comes the count. The count indicates the total records that have been included for computing this specific KPI, the door to triage time. To compute any time-based KPI, we are looking at 2 time points. And if one or either of the 2 are actually kind of missing, then that record is actually getting eliminated from the analysis.
And extreme outliers have also been excluded. When we say extreme outliers, we are referring to the erroneous time points, like triage being done before the particular arrival, or 24 hours after the particular arrival, the triage is actually done, which is highly unlikely. And then we have the descriptive statistics of mean, standard deviation, minimum, 25th quantile, 50th quantile, the median, and 75th quantile, and the maximum values. In fact, we are concentrating today on only two key parameters, that will be the median values and the mean values. The KPIs are presented as graphs to easily comprehend the baseline benchmarks. As we review the pre-intervention data, kindly note that the hospital names have been arranged in merely alphabetical order and in no specific ranking as such. The study that we have done, the Quest survey, has not been designed in a way that we can actually kind of compare the KPIs between the hospitals. A lot of standardization is actually required for us to have to do that, in terms of the patient load, in terms of the infrastructure, in terms of the knowledge, aptitude, and practice of the personnel manning the emergency department. So no such thing has been done between these particular sites. So we should not jump to the conclusion of trying to say which is doing good and which is doing bad, right? This study only aims at improving and measuring the key performance indicators intra-hospital, meaning the pre-intervention data is the benchmark against which the post-intervention KPI performance would be studied, right? So the median values are represented as orange bars and the mean values are represented by the blue bars. The standard notation used for time is HH and MM format throughout the presentation. So coming to the first KPI, door to triage time, that is the time interval of patient arriving to the triage being conducted by the nurse. The median range is found between 1 to 2 minutes across all the sites, and this is the median values. And the range of the mean is between 1 to 15 minutes. Coming to the second KPI, that is the door to doctor's time, the time from the patient's arrival at the emergency till the time the initial assessment is completed by the doctor. Here again, we see that the median range is between 4 to 5 minutes across all hospitals, and the range for the mean is between 6 minutes to 33 minutes. The third KPI, that is door to needle time for thrombolysis. All hospitals have actually reported single digits of patients requiring to undergo this particular procedure. Medicover, in fact, reported somewhere around 10 cases. The rest were all in single digits. So that's the reason you also find the mean and the median very close by. The median range is between 4 minutes to 2 hours 2 minutes across all hospitals, and the range for the mean is between 4 minutes and 2 hours 2 minutes. Same with this particular KPI, that is the door to mechanical thrombolysis. Again, very few patients, only 8 of them were subjected to this particular procedure, 3 in Medicover, 1 in NH, and 4 in Shija. So the median range is between 6 minutes and 38 minutes for completion of this particular procedure, and the range of the mean is between 6 minutes and 40 minutes. Coming to the fifth KPI, the door to pain assessment time interval between the patient's arrival to the first assessment of pain. The median range across all hospitals was just between 2 to 3 minutes, and the range of mean is between 3 minutes and 29 minutes. So the benchmarks already set in the pre-survey is quite high, and to beat them in the post-survey is a Herculean challenge in most of the KPIs, I would say. So coming to the sixth KPI, the pain score assessment to reassessment. So first they kind of do the pain score assessment, they bring in the intervention, and then they kind of reassess the particular pain. The median range is between 6 minutes to 1 hour across all the hospitals, and the range of the mean is between 17 minutes to 1 hour 22 minutes. The seventh KPI, that is the day to ordering the lab investigation. The median range is between 4 minutes to 21 minutes across all the hospitals, and the range of the mean is between 8 minutes and 45 minutes. The next eighth KPI, time from ordering investigations to the first review of investigations. Here we have allowed an overlap of 24 hours and not treated the data as an extreme outlier. There is a possibility that the investigations have actually been ordered in the ED but reviewed out of the ED, hence the long time intervals. The median range is between 20 minutes to 2 hours 19 minutes across all the hospitals, and the range of the mean is somewhere between 32 minutes to 47 hours and 32 minutes. Coming to the last time-based KPI, that is time from arrival to discharge, the median time range is between 30 minutes to 4 hours 14 minutes across all the hospitals, and the mean range is between 46 minutes to 4 hours 41 minutes. Now, what we also did is we tried to stratify this particular data based on the zone triage. The door to discharge encompasses all the intermediary activities, and hence we stratified the data based on this zone triage, the red, yellow, green, blue, and white, the red being most severe. And in the graph, the dark blue bar with the numbers indicates the overall mean time across all triage zones for the respective hospitals. The bar color corresponds to the corresponding zone patients, and the length, the average time for discharge. As expected, the yellow zone patients tend to stay longer than the overall average in most of the hospitals. Now, ladies and gentlemen, we are at a very crucial juncture in this particular study, wherein we have just completed the pre-intervention stage and moving into the post-intervention stage. But since we have all the site champions here, I thought it would be a good idea to share the percentage of records excluded from analysis as well. And now, this might be either due to the missing data, captured in the particular time point, or captured with errors. So the best practice is to mitigate this particular problem is to verify the records at the end of the day as we move on to the post-intervention phase, and discuss it with the central database team at NH to reduce the recall bias, and the data gaps can actually be plugged so that we don't have to kind of exclude many records. So here we get to see the door to discharge time. We have lost quite a few particular patients. So moving on to the to-do list, the final to-do list for the site champions here. Stop using the pre-intervention QR code yellow tags that were given to you, right? I am sure most of you would have kind of exhausted them by now, but in case you do have them, you please, do not continue to kind of use this yellow tags. From this point forward, I think today before you leave, the post-intervention tags, the green tags would be kind of handed over to you, and this is what has to be kind of used for the post-intervention phase. Kindly review the data quality, preferably at end of day, and incorporate corrections to avoid the data errors, so that when we kind of club these two, the pre-intervention as well as the post-intervention, we can have a very effective analysis to be done. It is tentatively planned that the post-intervention phase would be conducted between 1st June 22 to 31st August 22. Kindly adhere to these timelines, please. And ensure enrollment of consecutive patients during the post-intervention stage. So this is very important to ensure that the quality of data is actually kind of acceptable. Every consecutive patient rolling into the particular emergency department during your post-intervention phase has to be enrolled. With that, ladies and gentlemen, I would like to thank you all for a very patient listening. Thank you, sir.
Thank you, Dr. Jitendra. May I now request Dr. Vigneshwaran to come in, please?
A very good morning to one and all, respected dignitaries on the stage, site champions, and my dear colleagues. So basically, we all know time parameters is a key parameter in the emergency department, but there are also other parameters like incident rates that we need to look at. So for the quest study, we all know, so if you want to improve something, we need to measure that. So we took a holistic approach in that. We measured few key parameters, that is time-based parameters. We measured them using a red cap, an electronic format, which basically gives that real-time capturing of the parameters that we do. We also had few monthly data collected. So for that, what we did is, basically we circulated forms that included information related to the hospital census, the treatment and the number of staffs present in the hospital, treatment given, incubation rates, and other informations. No study is complete, especially quality improvement in healthcare, without patient feedback. So we also collected patient feedback in this study. Now we just wanted to emphasize that all this data that we are looking at is not for comparing across the sites as has been told before, because the practices are different across India. The idea is to see if we could see an improvement comparing themselves. And some of these data are basically like metadata for us that will help us to have a holistic approach to improve other aspects. It also helps us to plan our intervention strategies. So these are some of the parameters that we have collected. Basically from the hospital data, we have few incidental reports like medication errors, hand hygiene compliance, mortality information, patients who have lived against medical treatment, fall rates. Now, most of these information that we have captured are all reported data, not measured. Medication error is something which all the hospitals have a practice. They see the number of prescriptions given and see the errors reported. Hand hygiene compliance is something important, especially in the context of infection control. So each hospital has their own method of calculating it, and so we have calculated few important data. Mortality, when you are looking at mortality, we have not considered patients who are brought dead to the emergency department. We have also excluded patients who have been shifted to ICU and later had a mortality. We are focusing only on the events that had happened in the emergency department. Another common complaint or important thing that we look at is patients coming to the ER, but later, because of time factor, not being seen by the doctor. So some of these patients come in, but then they go without even seeing the doctor. So we are also capturing those information that is basically left against medical treatment. We are also looking at fall rates, fall the hospital census, the number of nurses, staff in a particular hospital, the number of shifts, and then we also looked into the number of beds for catering in an emergency department. So the average nurse-patient ratio across the hospital is somewhere like for each nurse, it is somewhere between 2 to 3.7 in few hospitals. So our intervention will also be focusing into these aspects. Now, like we said, no patient, no study, healthcare study on hospital is complete without having a feedback from the patient, because whatever we do finally matters only when a patient is having a good improvement. So patient reported outcome is something which is important. So for that, what we did is we devised a simple rating scale which consisted of 5 questions. Basically, we focused on 5 key domains, that is waiting period, doctors listening to the patient, general behavior of the staff in a hospital, and the patient's likelihood of recommending the hospital in future, and overall rating. So each question was given a score of 1 to 5, 5 being the maximum and total of 25. So the maximum score would be 25 for a patient. So what we did is we calculated the overall maximum score that could be obtained and then the average score for each domain. So we have measured the different scales over this, and we have almost equal representation in the scoring also, feedback also. Now what would be interesting is to see after the intervention with the improvement in the time factors, how there is going to be an improvement in the patient feedback also. So this would be it. Thank you.
Thank you, Dr. Vigneshwaran. And with that, we move on to the most awaited keynote address by our beloved chairman.
Good morning, all of you. Dr. Alexander Thomas, Dr. Brinda, and all distinguished participants. My greetings to all for this wonderful program that you organized here, and for your interest and enthusiasm to come and then learn something from each other is really a welcome one. I would like to congratulate Dr. Brinda and the DSRQ team for organizing this And also Dr. Suresh, who is here, the former director of DSRQ, who has been organizing this idea earlier when Dr. Shivan was here. So congratulations to all of you for this effort. And we heard from Dr. Alex Thomas that the genesis of this whole program and this interaction with Kasturi Rangan, Kiran Kumar. So it's really the inspiration that was created at that point in time. We are very happy that we carry forward and then take it further through these interactions between two communities of engineers and scientists in one side and doctors and healthcare professionals on the other side. There seems to be a bridge that was never to be crossed, but then actually we have crossed that, and we have a communication between them, sharing some sort of skills and capabilities between each other, and then seeing some result out of the whole process is really encouraging and happy to note. And today the program is structured to share a little more of that type of information amongst us, and then find out which are the new areas that the possibility of collaboration, working together to benefit all of us is possible. And that exploration let us continue from today and identify some course of action, some definite actions that we can take on responsibility of both ISRO as well as the Association of Healthcare Professionals. I'm really happy to see the type of analysis that you do and the type of presentations. I never imagined that you people look at numbers the way we look at. It's really a new revelation that you look at time, you look at data, you look at statistics. You know, I think I never studied medicine, so I don't have an experience of. I always thought that you are looking at microbes and and biology and the physiology of human beings, but also look at data in a big manner than I never imagined. That's really a new revelation. Maybe it's time for me to educated the way you learn yourself. So that's another opportunity present to us to understand. So before we go further, let me talk about something that we do and why this connection between space technology and healthcare professionals is important. And all of us in space sector do understand, as Dr. Brinda said, that we can't tolerate failures or errors of any nature. So why it is so is very, very clear for us. Why we can't tolerate errors of different kinds. I think we call about human errors and induced and otherwise also. So primarily the space sector is such that there are so much of complexity, and if an error occurs, of course it is catastrophic. There is no way to intervene midway and then correct it. I think this is also well known. Though we say that we are building mechanism in our space systems for corrections, reconfiguring, remodeling, through intelligent systems. Of course, many things are happening now in terms of software-driven systems, in terms of equipments where you have redundancies and reconfiguration is possible. Like human body is also capable of doing. We also have now satellites and launch vehicles capable of doing this type of things. And if nothing is possible, escape. Now, those also are there in many of our systems. Now, the intelligence is coming in space sector as well. So, but then the ability to tolerate errors is actually very minimum. The room is very narrow. I think the opportunities are very narrow. The window is very narrow. So that is why the importance of connection between medical side, healthcare, as well as space sector. I think this is well understood. And all of us in space sector, not only in ISRO, I think for anybody in space sector across the globe who have done something very substantial in space sector over the years, have a culture. It is true for ISRO, it is true for NASA, it is true for ESA or anybody in the world who have been successful in developing rockets, launch vehicles, and do some space applications. They became successful only through a training program or a culture in the organization which enabled them to be successful. And if you really go through what exactly are those behavioral pattern or the nature of their work, the training that you get in the organization, if you really go through and understand what is this. I have to go through my own journey of when I joined as an engineer in ISRO with no experience on space sector. We came into an organization and we learned everything internally, and there were no schools that people teach you. This is the culture that you have to learn. Some of them came from our experienced people who are there, like Kasturi Rangan or Dr. Madhav Nair or many others who are there, part of our seniors or people who are leading us. They said they conveyed through their work, through their behavior, certain elements which we absorbed into the system. And they tell us many stories also. I think stories are important. I'll tell you one story. When Dr. Abdul Kalam was the project director of SLV3, and they were just making a new project that they have to build a rocket, SLV3. And the management of this whole project has to be organized. And they were wondering how to organize a project of this nature. It was in 1970s, you should imagine. The concept of project management, the standard ways of managing big projects. The big is again a relative thing. You must realize the money at that time was only 20 crore for the entire SLV3 project. And in ISRO, it was told as a huge project, 20 crores. Now, but then for them, there were many questions with regard to systems and procedures that has to be put in place. It included procedures for review, procedures for configuration control, procedures for data dissemination, communication procedure across various teams, then procedures for review, procedures for documentation. All these were discussed threadbare at that point in time, and they created a structure. And that structure got evolved over the years and then got perfected. And by that process, we created a project management system in the organization, which is still surviving. Whenever we want to develop a new project, this project management approach is applied into that, and we are reasonably successful in accomplishing what we wanted to the realization time. So that is the learning. And I can tell you, at that time, there were people who were asking questions like this. For example, on review processes. Suppose somebody X is the designer of such a system. We make sure he is not reviewing it. Somebody else comes in who may not have any domain experience specific to that domain, but they will sit together and then ask questions. And through that process, we perfect the design. So we don't give full authority to a designer to design, but we create mechanism in between to ask questions. And through this process, they will be taken off guard sometimes. They will be angry with the questions. But then once a question is raised, it has to be answered. And this culture still continues in the organization. Whenever there is a review takes place, a younger generation of people are allowed to ask those questions, which will be a little bit sometimes discomfort to the designers of who are very senior people, but they still have to answer. And through the answering process, they make sure that they do the right rigor of design. We also create an excitement in the organization. This is also an important part of the whole process. We talk about the excitement of space all the time. We also ensure that younger generation are given responsibilities and they find pleasure in doing what they do on a day-to-day basis. So we ensure the management system is such that we create that type of excitement within the team. And only through excitement we can actually make great systems. It is not possible by giving assignments or jobs or tasks to somebody and ensure them to do something. It doesn't really happen. So we create that type of excitement is always there in the air, in the community. We also create a sort of a discipline. Discipline is coming on account of processes that we are set in. For example, if you have to go through a review process or a quality check process, we always say that you have to follow this process. And if there is a violation of the process, it is questioned and is simply not admitted. So for example, if you find in a hardware which you build, there is a deviation. We say the deviation is to be first reported at the incident location. The quality inspector must report in his logbook. It must be reviewed by a local snag review committee, and they should give a disposition or clearance. And if it has to be classified into different classes, it's a minor, major, severe, or whatever language they use. And if it is so beyond this point, it has to be upgraded to a next level where they will look at whether this can be corrected, it can be accepted as such, and what is the logic of acceptance. All these have to be recorded. Then finally, all this collected information must be given to a non-conformance review board, which is put by another senior person who will look at it. All these decisions are proper or not proper. So, and then finally, if it has a mission implication, it will get reported to higher bodies, which will clear the mission. So we create a mechanism by which if you don't go through this, it is not admitted. So this rigor is created in the system. And this is one of the rigor for quality, ensuring quality. So though we say sometimes there are people in the system, you should not think that everything goes very nicely. In every system, there are people who will question why I should do all this. this is such a silly thing. Why all this pain is taken to really? I could have cleared I know it, the whole system. I know what is implication of the design. I have been working it for last 25 years with this. Who else is there better judge than me who can clear it? These questions are always asked. But then we tell them that it is, though you may be a great expert, but please follow the system. Though you may be a great expert, but then we are creating experts through this process, and we are ensuring that all these are complied, which makes sure that nothing gets missed. And due to over enthusiasm, you don't really don't clear it on just like that, and later it will be known that the interplay of one system to another is never exposed. For example, a single person may not really understand the interplay. Like a human body, as you know, there are so many systems. Like rocket also has so many systems. We say structure, electronics, control, propulsion, aerodynamics. Then we have interaction with the ground systems, handling, assembly, testing, interfaces. Who can understand all this interplay? A single human being is capable of understanding it? Is definitely not. So we realize that the interplay of multitude of systems are always understood only in a group and never understood in an individual level. So we make sure that this interplay is always brought through this process of collective wisdom. So this is yet another quality that we create internally, that the collective wisdom of decision making is always encouraged. So it's basically an attitude. The space system success is simply an attitude. Even there are articles written from NASA specialists on this attitude. What is the attitude of a successful space organization versus a failing or a failed space organization? It is simply a feel of that anything can fail at any point in time. And this is the feeling that has to be created within the minds of the people. Like Sadhguru, all of you know Sadhguru, no? He has been so much there in all the social media. He always talk about death and also the mortality of human being. And he says that if you remind ourselves about the possibility of death just the next moment, even if I speak here, I can fall dead, or even if I just walk out of this, I may fall dead at any point in time. All of us are just immortal beings. And if you make ourselves aware of this possibility, then we'll do a wonderful work for the time which you are living. Now, this is a simple message, but this message is very powerful message that every human being can take on and then do wonderful work whenever they are active and thriving. So for space system is same feeling that if you tell that anything that you can see today can fail. So you just ask the question to yourself, how always it can fail? This question is asked internally every time and every design is made. So we look at the possibilities of failure in all the time, not the possibility of success. And through this questioning of nature of possibility of failure, that you actually make a very successful product. So this is the nature. So all of them are very skeptical guys in space. You will not see them. I may be like smiling, and you will see only very few people here who are really smiling. But most of them are very skeptical guys who are good designers. We say good people who actually do successful things. They always ask this very uncomfortable questions. And those who have the ability to ask this uncomfortable question only will succeed. That is the feeling in all the space enterprises across the globe. We also evolved these systems in ISRO, quality systems, for example. We have created it in a manner that over the years the development has happened. I think many of you would have already interacted and understood. Some of you have been with Dr. Suresh earlier, the DSRQ interactions we had, and some of the learning from the quality practices in ISRO also would have been benefited for your team. So I look forward for further interactions on this and to understand this genesis of quality system creation in ISRO, different layers that we have created, which I mentioned for non-conformance, but also for quality clearance checks and balances. We have created a very structured manner. And now we have a new mission that is coming up, the Gaganyaan. We have been launching satellites, we have been launching rockets for those satellites, but then the moment that we put human beings on top of it, it is a different issue. Just you were mentioning that the aeronautical domain, as Devi Shetty was telling, that that domain is one of the safest. Taking a car and driving on the streets of the Bengaluru is the most unsafe thing. But then taking a flight is the best, the safest mode of transport available today. And is the rocket travel of human space flight still safer than aircraft? Yes, it is. And by statistics, flying as an astronaut is still safer than flying on an aircraft. By statistics, of course. But then, but to make that much safe, you need to invest quite a lot on various elements. So we are also in the process of learning that. It involves many aspects. We call it human rating. We call it human rating of rockets and preparing spacecrafts which are human rated. And we ourselves are learning it. And let me be very frank in telling you that we are understanding what is the extent of human rating of different systems. We can talk it in terms of numbers, like enhancing the reliability of a rocket from 90 plus to something 90 plus. So some number, never 100%. Also looking at the factors of margins to increase from certain 1.1, 1.2 to 1.4, 1.5 or 2. Then look at the number of test enhancement from 10 to hundreds of tests to prove that they don't fail. We also look at various measures of quality to increase the reliability, and then finally improve the redundancy, fault tolerance in the systems, etc., etc. But that doesn't make the real human rating. The real human rating is again a part of the culture. We understand this, all this can be done very systematically, but if you don't have people who actually look at it in a way which has a culture. See, for example, neatness is a culture. Now, your ability to put a paper throw like this and throw, that prevents you psychologically that you don't actually do it. You will feel that it is better to put in my pocket and put in a waste bin. It is a part of the culture. So a human rated rocket will be developed only when the team who is actually building has that culture, that every small thing that you do has to do with the life of the person. This has to be internalized. So we communicate this in spite of all these numbers, all these calculations, all this work which we do. We must make sure the people who are doing it must be always attentive to the possibility of an error. We have gone through various failures also and issues where errors have really happened. Errors could be different. One is not understanding a system and doing something. It's also an error. I have not understood the whole process or mechanics of how the system works, but designed something. We recently had a static test failure of one of the motor, in which a flow field and a thermal issue which will cause the margins on this to be rolled was not understood, because the computation which we did for that was not adequate to capture the behavior. It is a fundamental knowledge lacuna that caused that failure. But if somebody didn't actually put the thickness of the material there, it's a basic error. So I am looking at the second aspect of it, that you have not done what is due diligence in doing what is needed. This has to be totally prevented. It can happen only by the process of culture. So this culture creation is the task of the management today. And we continuously communicate with the team to ensure this happens. We are also working on various activities related to medical field. Of course, that will be definitely discussed today. We work on small things based on the knowledge that we have on material science, manufacturing, design, flow dynamics, interaction with the medical systems, etc. So we do that. I think probably that's not a major part of our work, but still it is something that we want to continue and do in the days to come. And also to understand doctors better. I think we scientists, engineers, we build machines, and we don't have the feel of human beings. Okay, unfortunately. But when an astronaut sit in a machine and try to operate a machine, there is something else sitting. It's not a machine. He has to handle equipments, and then sometimes he has to put on a switch. What is the state of mind to put on a switch to do certain things cannot be understood by scientists. So what we do is we have astronauts now. There are 4 astronauts now part of the Gaganyaan. We talk to them, and they sit in the cockpit demo simulation and then go through this process and tell us, your equipment placement is not correct. The lighting is not correct. The edges are causing problem for us, discomfort, for feeling comfort within that, and to operate certain things are not good. The software is not giving us the clue in what way this goes. The display has to be changed. So there is a lot of understanding happens. We also are looking at how doctors can connect with this system design, the human spacecraft design. So there is an interaction happening between doctors and engineers in designing the human craft. possibly this interaction will grow in the days to come. If you have to conduct a successful human space flight and sustain it in India, we need a strong pool of doctors who will get involved in this human space flight mission as well. So there are opportunities for connecting with the doctors, not only for emergency medicine doctors, but also various people in this profession. Today, Dr. Alex mentioned about some of the tasks that he has given to us. We discussed in my room on those 2 assignments that you've given. I'm very happy that we will take on this and do very, very effectively in the days to come, like the geotagging as well as the impact of climate change on healthcare issues. And Shantanu is here, Dr. Shantanu. He is an specialist in this domain, and definitely he can lead this activity and get it done through the chain of systems that we have. So connect with him and do whatever interactions required. It can be taken up as a project for us to do this. So looking forward for future interaction, and all the very best to you. And thank you so much for coming to ISRO headquarters. This is a place where only people are there. No equipments and machinery for space are there, unfortunately. So you will not be able to enjoy what we do really. So, but however, we will, through this interaction, probably we can know each other, and maybe at some point in time, we can always visit some of the ISRO facilities and see really what exactly we do in terms of technology, building systems, etc., which is really fascinating. And many people in this country itself don't realize what exactly we do. So please look forward an opportunity and take some time off your hectic schedule to find some time to come to Sriharikota if possible, and then see one launch in the recent, this year itself. There are many coming up. So wish you all the very best, and thank you so much for this opportunity.
Thank you very much, sir. One, for appreciating the work being done by the medical professionals, and secondly, for extending helping hand to the medical profession in terms of collaborations and the future collaborations, which we are very eager to take forward with the ISRO. And with that, may I now request Dr. S Srinath Kumar to kindly deliver the vote of thanks, please.
Good afternoon, everybody. It's a great moment for us to be in front of this gathering. I would like to have a quote here. It was the epoch of belief. It was the epoch of incredibility. It was the season of light. It was the season of dark, and it was the spring of hope. I think this quote is apt today for me standing in front of this august gathering, because we all know that emergency is the place where a lot of people come in agony, and emergency physicians are the one who has to face. I always tell my people that we are treating a patient inside a hospital in another hospital, because emergency itself caters to everybody, because we have to satisfy not only the patient attenders, the management, the on-seeing people who are coming to bring the patient. And you know, sir, every patient, when there is a trauma or when there is some pediatrics, another 10 people will accompany them, and we have to satisfy them. So it was really thankful. I can't tell that this is a vote of thanks, because we are in between the study which we are doing for the Health Quest. So I would like to take this privileged moment to wholeheartedly thank our ISRO chairman, sir, who is here and addressed us in the right way to take forward. Shri S Somanath, sir, Chairman, ISRO and Secretary, Department of Space. And also the other ISRO team members who are always behind us, who supported us, the former chairmen, Shri Kiran Kumar, sir, and Dr. K. Shivan, sir. And then Mr. Selvaraju, Dr. Brinda, Dr. M.R. Suresh, Dr. Prakash Rao, Ms. Sri Raksha, and Dr. Kumar. All the ISRO team members, we have been interacting with them past 6 years, and they were being very eager to help us in each and every moment which we are shared here today. And I will not be right if I don't thank our beloved Association of Healthcare Providers of India President, Dr. Alexander Thomas, who is a great visionary in healthcare, always thinking about the quality care. for the patients coming to the hospital. He has been taken care every part. Let it be the hospital, let it be the quality, let it be the accreditation. And then my own chairman, Dr. Devi Shetty sir, who has been a backbone for all of the healthcare providers in India and giving motivational speech every time and taking us in the right way. And then the semi-board members who are sitting here, Dr. Venkatesh, President, Society for Emergency Medicine India, Dr. S Srinath Kumar, who is not among us, please give him a big hand, because along with me, he was another person who has always been there in this quest study right from the beginning. He started the whole process, protocol, and we always tell him as a quality man. And he also represents the International Federation of Emergency Medicine as the chair of quality. Thank you very much to Dr. Srinath Kumar, who is our secretary for Society for Emergency Medicine India. Dr. Sai Surendra, who is a joint secretary. Dr. Shri Somanath.S, who is the treasurer. Dr. Imran Subhan, who is a past president of the Society for Emergency Medicine India. And Dr. Satish Kumar Kailasam during his period, where we launched this whole program. And also we have Dr. Mabel Vasnak, who is the head of emergency services, who started a career from St. John's, took the path to the Manipal group of hospitals. And then the Planet Aerospace, Mr. R.K. Rajangam and Mr. L.S. Satyamurthy, who helped us in the initial part. And then the NABH chairman, the then chairman, Dr. B.K. Rana, who was there with us, and the CAHO, Dr. Vijay Agarwal and Mr. Samir Mehta, who helped us. And then the experts currently connected with this study today is Dr. Alexander Thomas, Dr. V.C. Shanmugam, me, Dr. Srinath, Dr. Srinath Kumar, and the other person who told about all these quality improvements was Dr. Albin Sigamani, who was the group head for research in Narayana Health, who introduced about this whole system and the red cap, which the 11 hospitals which have been utilizing this. And based on this real-time app, which Mr. Jitendra sir had presented to you, it was very enlightening because we could see the real-time data every day and look into how we can improvise. And today, whatever we had presented, and we had done a training sessions for all the 11 hospitals which were participating with us. And then Dr. Vigneshwaran, who is the current research head at Narayana Health. Thank you, Dr. Vigneshwaran. And two very young and enthusiastic, Dr. Reshma JK and Dr. Manzoor Sheikh. These two were always been behind all the hospitals to get the data and present it every week on Monday, which sir was telling the 100 Mondays which had gone by. We could just imagine whenever Monday comes in, we used to see that, okay, today we have to present the whole data to the gathering. And then Ms. Deepthi Bajaj, who was supporting with Dr. Vigneshwaran. All the managements of 11 hospitals, I would like to take this opportunity. Apollo Hospital Bangalore, Apollo Hyderabad, Apollo KH Hospital Vellore, CIHSR Hospital, Continental Hospital, KIMS Hospital Trivandrum and Kollam, Narayana Health, Mehta's Hospital, Medicover Hospital and Shija Hospital. So these 11 hospitals, I would like to thank their managements, because without their support, we could not have brought this study and take this forward. And all the representatives who are sitting here, the semi-board members, the semi-members, everybody who are sitting here had been participated and given us the time from there and traveled across the country for a single noble cause, that is to improve the quality care of patients coming to emergency departments. All the delegates, semi-members who are consistently supporting for the quality improvement projects and are here with us to motivate us and be with us. Dr. Jitendra sir, who was always with us, providing us, which I was telling, the red cap analysis which has been done every Monday. He used to present to us and say that you are on this path and you have to improvise here, and what is the data missing, what is the data to be included, and how to take it forward. And this was not possible at all without your support. Thank you very much. So with this, I think we have, if I missed anybody else, I'm very sorry. Thank you all. Jai Hind.
Thank you, Dr. S Srinath Kumar. Before I bring the curtains down on this inaugural function, I would like to thank Dr. Srinath Kumar for having been one of the driving force behind this study. And before we bring down the curtains, you have a wonderful quote by John Fitzgerald Kennedy. Quote, many years ago, the great British explorer George Mallory, who was to die on Mount Everest, was asked, why did he want to climb it? He said, because it is there. Well, space is there, and we are going to climb it, and the moon and the planets are there. New hopes for knowledge and peace are there. John Fitzgerald Kennedy. With that, we bring down the curtains on the inaugural function, and we break for tea. Thank you. Yes. Before we break for tea, we'll have a photograph session with the chairman. Sir, thank you very much for having accepted for this group photograph.
Recording has started.
Hello. Hello.
Welcome the participants to the post-coffee break session, and we have Dr. N Venkatesh making a brief presentation on emergency care in India and about the Society for Emergency Medicine India. Dr. N Venkatesh, please come in, sir.
Hello. Good afternoon to all. I thank ISRO and AHPI for association with SEMI for doing this wonderful project which you already seen. So I'm just going to take a few what this SEMI's bird's view. So this is our national board. So Dr. Hari Prasad is the chairman and followed by Dr. Mahesh Joshi and myself president, and Dr. S Srinath Kumar is the secretary and Sai Surinder joint secretary. Dr. Saujanya is our national treasurer. So with all the vice presidents. So as we all know, the emergency medicine in India, which started in the year 1999 with the SEMI also started in the year 1999. So most of in India, what we see is in emergency medicine, the pre-hospital care. It all started with the private sector. So in India, almost 80% of the healthcare is by private sector and 20% by the public sector. So the pre-hospital care initially started by the private sector in the around 2000s, followed by the government, which started with 108 in the year 2008 and spread across India. The same with the air ambulance services. It started in the year 2000 by the private sector. Now with the Kerala, which started in 2016, the government of Kerala announced the air ambulance services. So these are all the programs what in India are running with the post-graduation for developing the emergency physicians in India. So this is our Society for Emergency Medicine, which is spread across in India. We have covered almost 80% of India with our state chapters, and remaining around 20%, we are covering with the vice presidents of the state chapters, and we are planning to implement our state chapter shortly in those areas. So this is our annual national conference, MCON, which happens every year with both national and international faculties, with all scientific fiesta, which makes all the emergency physicians to update their knowledge. So also this semi-host post-graduation for the postgraduates conferences for upgrading their skills and the rapid revision program every year, that is SEMICON. So which makes the students to completely know about the emergency medicine and prepare for the exams. So all with the state chapters, there will be monthly academic meets with continued medical education programs in each state, which will be done, and it will be updated to each state, and we will be in discussion. A lot of international faculties also will be keep coming whenever they come to India. So we'll invite them and give their expertise opinions to us. So how we do our emergency medicine spread across? So we have a process for development of emergency departments and also the capacity building. So first we start with our inspection and standardization of the departments, and we create an academic training center, and then the examination and followed by certification of emergency medicine. So once it is done, we also go with the quality accreditation of those institutions. So this is our semi-providing examination for a graduation ceremony, which we do in our MCON National Annual Conferences. So there's a recent in 2022, which we did in Bangalore. So this we have with the central and state promoting our emergency medicine. This is one of the conferences which happened in 2018 in Bangalore, where our central health minister was also one of the part of it. Also this with in Delhi with the Vice President of India, giving the thoughts on emergency medicine and SEMI. So this we have already seen our the tie with ISRO and AHPI, what the study we are doing. So I think already we are in the phase now, and the post-intervention phase will be continuing now. So SEMI is a full member of International Federation of Emergency Medicine, and most of our SEMI are in the SIG groups. We are in the geriatric EM, we are in the triage, we are in the trauma, we are in disaster management, in the quality improvement, and also on the patient safety and gender-specific issues. So most of our SEMI board members and also the state presidents and chapters presidents are also in a part of the IFM board members. So these are all the international agencies where SEMI is associated with. So we're with IFM, Asian Society, George Washington, Royal College, and many more. So these are all the national agencies where the SEMI is associated with, and we work with in collaboration with them. So the recent 2 years back, 1 year back, the SEMI associated with Quality Accreditation Institute and formed the guidelines for quality upgradation of each institution and their inspection. So we are doing this since 1 year, and already there are 4 hospitals. So we have inspected this. This is a first of its kind, where the quality parameters are checked only for emergency department. So this is one of the recent additional one. So this is our national journal, annual journal of Society for Emergency Medicine. So thank you very much.
Thank you, Dr. Venkatesh. We now have a very interesting presentation from the ISRO, Medical Emergency Systems developed by ISRO. Shri Sandeep P. May I request Sandeep sir to come in, please? Oh, thank you very much. He is from the Technology Development and Management Group of the VSSC, Thiruvananthapuram.
Okay. Respected dignitaries and all members, very good afternoon to all of you. This is a brief presentation on what are the medical emergency systems that we have developed during the COVID-19 pandemic time. So basically, as our chairman has told, this is our basic expertise. In our launch vehicle center, we have expertise in aerodynamics, mission design, control systems, and whatever we are seeing as highlighted are those expertises which we have just integrated into these medical devices. We have, for instance, the control system team, which is making the steerings for the launch vehicle. They have developed 2 number of ventilators. We have the teams which is doing the control system, that is how the rocket parameters, the rocket performance parameters are to be controlled. That team had done the control for the mechanical ventilation parameters, the pressure, the volume. Basically, the principles are the same, whether it is for the rocket or whether it is for this multidisciplinary systems. So that team has contributed in this development. Then the avionics systems, in fact, the team which makes the flight computers, they have developed the main control electronics for this ventilators. We have the chemical systems, which makes the thermal protection systems. They have done the oxygen concentrators, which is basically a chemical absorption process. So we will just go in brief about all these systems, what are the basic principles and how they work, and what are the things that we have just carried out. Just move on. So these are the 3 ventilators that we have developed. Vayu is a ventilator which is a blower-based system, which is in par with any ICU modern ventilators. And Prana is a ventilator which is an automated compression of an ambu bag. It is working on that ambu bag compression principle. Swastha is a different class of ventilator in the fact that it doesn't require any electrical power for operation. In fact, when the pandemic started, we were not knowing where this was taking us. So suppose we reach a situation where we don't have any integrated circuit or electronics, where we reach a situation where the demand for ventilators become very high, what is the way out? When we thought like that, only our team has conceived this ventilator can work, achieve the basic moves without any electric power, just with a pneumatic supply, it can work. And Shwas is the oxygen concentrator that our team had developed. These are the general capabilities of the system. The individual systems are much more capable, but all the systems will cater to this basic requirement. This is Vayu. It is a compact tabletop model. You can see on one side you have the provision for connecting the ambient air or oxygen. This can work on ambient air. If hospital oxygen is not available, ambient air will be compressed by a blower and it can be delivered to the patient. On the other side, we have provision for connecting the breathing circuit. Also, there is a provision for connecting the proximal flow sensors. If we want to do a flow triggering, that can be connected to the other end. The expiration gas will be sent out through the same side where we have the oxygen and air inlet. Inside, we can see that green color is a control electronics board which controls the blower, which does the acquisition from the sensors, the pressure and flow sensors. And also, this is a compact model. On the top, we have a display which has the HMI system where the parameters can be set and the current parameters will be displayed. This is the basic circuit and working of the system. On the left side, you can see the air inlet and the oxygen inlet. If there is no oxygen available, it can work on ambient air. And if an FiO2 is to be controlled, you can give an oxygen supply also. It goes to the inlet of the blower. And blower is the one, the speed of the blower is the one which basically controls the pressure or the volume, well, pressure or the flow that is to be achieved. On the output of the blower, we have the sensors for the oxygen concentration, the flow meter, the pressure sensors, and it goes out through the breathing circuit to the patient. The expiratory limb is also connected to the ventilator, where we have control valves, which can be solenoid valves and even proportional control valves, by which we can control the PEEP. That can also be a setting which can be controlled. Instead, we also have an electronics and an HMI module, which interacts with the doctor for setting the parameters. So these are the brief specifications of that. We have the blower speed as the main control parameter for the system. This is the Vayu ventilator. I will just move on. This is Prana. It is basically this is a kind of ventilator which many people have made during the COVID-19 pandemic. We have an ambu bag and the compression of the ambu bag is automated. It is automated through a DC motor which drives it through a gear train. Even though it is automated, we have a closed loop control for all the ventilation parameters. The pressure, the flow, the volume, everything can be controlled in closed loop. There are sensors, there is a control electronics which does that control. And even the expiratory limb, there are valves which can be closed and opened to control the PEEP. This is a circuit of Prana. What we have marked as number 2 is the ambu bag, and which is compressed by 2 arms, which is controlled by a DC motor through a gear train. The output of this bag valve mask, it goes to the inspiratory limb to the patient. There are sensors in that for pressure monitoring and even sensing the FiO2. Of course, FiO2 control is not actively done in this. We have to do it externally.
And the expiratory limb again goes back to the ventilator. There is a solenoid for controlling the PEEP, which can be closed and open for controlling the PEEP. So this is a circuit. Again, it has an HMI. In fact, it is the same HMI which is configured for both prana and vayu, which can be used for setting the ventilator parameters. Then there is a control module, the basic control electronics, and a power supply which is catering to all the sensors, controllers, and the HMI. This is the configuration of prana. So there is a unified controller and a HMI system developed for both these ventilators. We can set the ventilation parameters, the ventilation mode, whether it is volume control, pressure control, or pressure support. And for each of the mode, we can set all the parameters that are required. Then there is an initial machine check also possible in that. The left side are the parameters that display are the achieved parameters, and the right side are the parameters that we have just set. Top we can see the block diagram of the controller. It is a microcontroller, PIC-based microcontroller, which interfaces with the drive of the motor. It in fact drives the control valves, the solenoid valves. It acquires all the sensor data, the pressure, the volume, the flow. Also, it interfaces with the HMI. It is a serial interface to the HMI module. From the HMI module, it is in fact the brain of the system. It gets the input from the HMI and controls all the motors, valves to achieve the ventilation parameters. So this is the other ventilator, which was a novel design. In fact, a patent is also granted for this. This works without any electric power. It works just on pneumatic power. The basic principle is simple. There is a cylinder. That cylinder has two chambers. One side is a control chamber and the other side is a respirator chamber. Once we apply a pneumatic pressure to this control chamber, it just reciprocates. If you want to increase the speed of reciprocation, we can increase the supply pressure so that we can achieve different breathing rates. There are different orifices put in that so that the inspiration-expiration ratio can be controlled by manually adjusting the orifices. There is a pressure relief valve at the outside so that the maximum pressure can also be set. So this is the basic working, and what we are seeing on the bottom is the respirator chamber. This chamber was first initially tested to prove the concept. This is the test setup for the chamber, and once it is proved, it was made into a detailed ventilator. Whatever we are seeing on the right is the ventilator. If we want to display the parameters, we can have a display and a symbol acquisition system that doesn't do any control, but we can see the ventilation parameters and control, make the manual controls accordingly. So whatever we are seeing in black are the mechanical controls. The tidal volume is adjusted by the sweep of the piston. There is a mechanical control so that we can adjust how much the piston moves. The pepper minute, as I told, it is a pressure regulator, and the IA ratio can be controlled by orifices. There is a relief valve put in the expiratory line, which can be used for controlling the PEEP. So this is the third model of the ventilator that we had developed. So this is the medical oxygen concentrator that again we developed during that pandemic time. It works on the pressure swim absorption technology. In fact, the air is taken through a compressor and it is passed through a zeolite bed where the nitrogen is absorbed. The remaining oxygen goes to a chamber where the concentrated oxygen is stored, and based on the requirement, we can just open a valve and use that oxygen. After some time, once the bed gets saturated, it is vented to atmosphere. By the time the second bed will be absorbing the nitrogen and concentrating the oxygen. So it is cycled between these two beds, and we get the required oxygen concentration at the output. So this is just a brief glimpse of the devices that we have developed during this emergency time for our societal needs. This is all. Thank you.
So,
these devices were made and this technology is transferred to industries. For the oxygen concentrators, almost 6 industries have developed the proto model. Ventilator technology is also transferred to industry and they are in the process of making it. We have just made the technology, madam. This technology is transferred to industry for this commercial utilization. If there, No, units are made. Whatever we are seeing here are the units what we have made and tested, and it is achieving all the parameters. Tested, qualified. Yeah.
And I think that's another project which AHPI can think of.
Mhm.
highly impactful for us.
Mhm.
And also probably
that ISRO will showcase all its capabilities and what is available. And we will call all the experts from all over the country and probably you want to add something?
I was suggesting the next we will have it in a bigger scale where all the experiments we have tried, he has presented only few of them. We will have an exhibition and then also we will also discuss about the 9 or 10 technologies we have understood. Maybe we will also collect the proposals from medical side and we can have a very good.
One point just I would like to add is developing a ventilator or whether it is a launch vehicle, it is a multidisciplinary technology. We need electronics people, we need mechanical team, we need chemical team, and all these expertises are available in ISRO. And compared to making a launch vehicle, to be frank, making these systems are relatively simpler. It is only the culture that Chairman was telling, which makes this multidisciplinary team work together, share their knowledge, do a system design, and make the technology. That is what we could do during that. In fact, all these things started with a WhatsApp message from the chairman. He just sent a WhatsApp message across group, and immediately many teams started working together, agglomerating and sharing ideas and coming up with systems. What we did is just a formalization of this after some time. So that then it went to the formal review process and the proper design, and this has come out.
Of this thing, we can discuss among the health professionals about what are the needs, give it to you, and I think using your technology, come out with our keyword is affordable. So we will do it with you and then ensure that it is marketed so that profit is important, but it's not that it is affordable. At the end of the day, we are looking for affordable quality care.
Sure, it can be looked into. Even our launch costs are very low. We can do things affordably and we have the technology also. It can be looked into.
If there are no other questions, I think we should congratulate Mr. Sandeep for a wonderful presentation. We are all proud of you, sir. We are all proud of you. Thank you very much for that wonderful presentation.
In fact, it is a big team that has done. I am just representing them.
I know.
It is a team of the expertise that is required for this.
When we thank you, we are thanking the whole team.
Yeah, fine. Thank you.
So we have another presentation from ISRO. Dr. Geethai Krishnan C, Deputy Director, Safety, Reliability and Quality Entity. Very much required for the medical profession. Please come in, sir. He will be speaking about the human rating and certification for manned space missions, a paradigm shift in safety management.
Good afternoon to all. Actually, this is a unique experience for me. In the sense, when we go to doctors, we don't speak. We listen, they prescribe, we take away and religiously follow it. I think that today we are only stopped. So in the next 15 minutes, I think I should be able to give you some couple of takeaways which will be useful for you. That is my motive. When we say about the risk management, I think doctors community is the best community which can appreciate more about the risk management because you deal daily it is. So today what I am going to talk about is how the risk management is done in the, maybe I'll calm down. No, this is comfortable with my neck. So today I will be talking about how the risk management is done in space domain it is. So when we talk in space domain, when we say mission success, first it starts with safety. Safety of the people who is working on the thing, and safety of the people who is involved in operations, and safety of the public, and safety of the wealth. More than above all these things, when you are going for human space missions, is the safety of the astronauts who is sitting in that. So as Chairman morning it mentioned, he mentioned that when you go for the human space missions, the safety of the astronauts is achieved through the human rating. So today my objective is, I will be, for the human rating, we are adopted many best practices, which is being followed and we are implementing it. And I may not be able to tell you all the things. So I have selected a couple of best practices because of the limitation of time, and I will be able to give the flavor of the thing. What are those things? Okay. So my presentation, I will go like this. First, I will just give you what is human space mission, so you can appreciate what it is. Then what is human rating of systems, and two best practices I want to convey to you. One is the human factors method, which addresses the human errors and mental workload. And another one is a probability risk assessment, which is one of the best tools available today in the world for the risk management, which is adopted by the nuclear industry, chemical industry, oil and natural gas, and space domain. All this. So this is one of the things we started exploring past 4 years. We are learning it. I thought it will be definitely applicable. It will be applicable in the things. And by going through the literature, I found there is a scope for all this, both of these things in the medical domain. Okay. Then I come to human space mission. So this is our Gaganyaan vehicle. Oh, sorry. This is our Gaganyaan vehicle. So it's total about 450 tons, right? And it's about height of 55 meters. And this is the solid stage. Middle one is the liquid propellant stage, and above that cryogenic stage. Here is the amplified view is there. This is where the astronauts are sitting. And this you can see it is called crew escape system. It's like an emergency exit. If any issue is there are 9 motors which will give the very fast acceleration and which will take the astronauts away and make them land in a safe place. And zooming of the crew model, this is the thing it is. So just give you idea what it is. Then, so how it is going? So all the mass, everything 450 ton, it has to lift off, and every stage is given the duty of imparting a certain amount of velocity. After imparting velocity, we have to disengage it, and when we throw away it, we have to safely throw it, because it cannot come and ongoing stage should not be there. So every stage will be thrown out, and if it is a nominal mission, this crew escape system, which is the emergency exits of no use, so that will be thrown out after something. And finally, this, what is the crew model? It will go to the height of 275 kilometers at the speed of 8 kilometers per second. It is to be injected. So this 8 kilometers per second is injected by the 3 stages. And more important than this is when we are separating the stages should not come and fall on where the damage should not be there. It should be identified places it has to fall. And more than that, launch pad, it should be very clear. It should not have any risk of explosion or anything. And once it goes to the orbit, it is going to be the orbit in a number of days as planned. But when you are in the orbit, it's a vacuum. But astronauts are there, so you have to create a Earth-like atmosphere in the crew model. For that, you have to create a system on that. So then once the mission is over, they want to come back, you have to give a D-boost. D-boost means the velocity should be deviated inside towards the Earth. And when it's coming down, the temperature, because of the aerodynamic heating, it can go as high as 3000 degrees centigrade. So we have to protect the astronauts inside from the heat being created. And this 8 kilometers per second has to come to 8 meters per second around that when they touch down the thing. So we have to reduce the velocity by releasing the parachutes. So this is the complex thing involved in the human space mission. So we have to ensure, and as mentioned morning by our chairman, once you lift off, there is no control. Only you can see. You cannot do anything. It is so everything to be pre-planned, everything to be all failure modes to be addressed, all whatever or wherever it can go wrong, how it can go wrong, everything to be addressed and pre-planned, and you have to have the plan for that. It is. So when we come to the Gaganyaan or any human space missions, our primary objective is the crew safety. And next is range safety. When you say range safety, I told you the separated stages should not fall in the land or where people are living, all those things. Then above all these things, then only we look for the performance you have to inject at the altitude at the particular speed. That's it. So when you are taking the crew safety, we are mainly depending on the human rating of all systems. That is the one thing. And these points were nicely covered by chairman. We have to go for redundancy, we have to increase the margin of safety, and you have to go for the crew escape systems. So when you go for the human space flight, what are the challenges? I can highlight 5 challenges. First is, I will start from the psychology, because the crew is going to be in isolation in the crew module for a longer period in the confined place, and only the 2 people or 3 people will be there to interact with them. Then it is going to be a physiology things, because high forces will be acting and you will not be having the Earth-like ambience there, all these issues. The environment is again another issue, and mission strategy. So all these 5 issues have to be critically addressed compared to the earlier what we have been doing the satellite launch vehicle mission cities. So all these 5 are mainly addressed through the crew safety, these are the 5 things. We plan mission clearly, how to go, how to separate, what are the possible failures, that is a mission strategy. Then we go for the environmental control and life support system. This ensures that astronauts feel as if they are living in the Earth. That system will be ensured in the crew model. Then above all these things, you have to go for the crew rating. Then mainly physiology, psychology is addressed through the crew selection and training. When we say human rated vehicle, actually 3 mainly you have to address the thing. One is accommodate the crew. You have to accommodate the crew as if he is living in the normal acceptable conditions. Then not only thing, he is expected to do some activities. So the system should give the provision that his capabilities are mainly utilized. It is then whatever the design we do, whatever the best, there is always a risk going to lie in the system. That is called residual risk. So we have to make the residual risk acceptable. For that you have to identify the hazards and control all the hazards. And in spite of that, something happen over and above, we have to have the recovery system if something goes wrong. So these 4 aspects is the mainly principles of human rating. So these are the various domains how the human rating is measures are occur. I am not going into detail. Just I can touch again. Morning it was covered by chairman. If, for example, we structures we make it more stronger, and propulsion we operate in the less condition favorable condition, and we go for the quad. Wherever the one chain of the electronics is there, we make it 4, so that one failure can be accepted, 2 failure can be accepted. We call it fail safe, fail safe. Like that conditions are there. These are the design philosophies. So all these things will be adopted. So then we have done the human rating, but now the question comes: how to say that it is human rated? How you are going to give a confidence on that? One is we have to assess the risk associated with the decision, final decision, every design decision. We have to do that, and we have to raise the potential for the uncontrolled hazards. So when ISRO, we for main human rating for past 4 years, once we started Gaganyaan, we started implementing many human rating measures. There are these 2 methods I highlight here, because again I find it's a core scope for applying in, applicability in medical domain also. One is human factors method. So that to ensure that human related errors are prevented and mitigated. Second one is risk management, PRA. This is to identify the failure scenarios and manage the risk. So these 2 just I'll give the touch upon. Again, you have to excuse me, I'm not going into details of the thing because of the limited time available. My aim is to give the flavor of the thing. Actually, some of you might have come across this. It's called cheese model. It is. Cheese model talks about when a hazard is there. Hazard is defined as any event which can cause potential harm to the environment, people, or facility, all those things. So hazard is lying there. The hazard becomes accident when before that you have to put a lot of defense layers are there. Here I put is to convenient that for corona thing, if the virus is there, there are defense layers. Each layer of the cheese is like a defense layer. It is. For example, mask and social distancing, cleansing, wash hand. So if everything is proper, this will not come and infect. That event will not occur. The accident or incident will not occur. But every hole in the layer is a flaw in the system. It is in the particular layer of flaw. If unfortunately, if all the flaws, the holes lie, a set of holes lie in the thing, then it is going to be the accident or incident. It is. So this is it can be applicable for anything. When we come to our system, hazard is lying here. When it can become incident is engineering control is missing, administrative control, behavior control, all these things are missing. Then there is a scenario. Then it goes to the thing. It is. So when you go through, one can go through the literature and find 90% of the accidents in the workspace is based on the human error. It is. And 75% of aircraft accidents, it is due to the human error. This is a literature states that statistics. So human error is one of the risk factors in the anything, and it is happens here also. In case of spaceborne, it can be human error due to the after ground command people. It can be astronaut. It can be designer. Any human errors can be there. I think. So how to prevent the human error? So nowadays, recently, this human factors is the one domain. It has recently come up, which says that the one of the defensive layers you have to be human factors, and which have to address a set of things. It is. So when you say human factors, it is about people living and working situation, how they live and how they work, working environment, and how they are going to the interface with the technology and the environment, and relationship with other people. That is interpersonal. That is also important. Suppose the astronaut is communicating with ground person. The communication there should not be errors. It should be properly understood. So there should be a communication protocol clearly, like pilots and aircraft things. They are using the things. So these are the things. Then when you want to say that attribute of the human, it is first anything overall the system, human is not behaving, the system is not behaving as he is expected. And some of the existing things are not captured methods. And it impacts negatively on the overall. So these are all things when it happens, the human error is there, it happens, all these things. So it is basically, it is neither engineering domain nor the human scientist domain, it is between the thing, the interface. That is the reason it has been missed over the years. Now it's a great focus has come into here, this area, and there are many works are going on in this. Okay, so when we are saying human factor methods, these are the 9 methods, human factor methods available. Just to give idea only, I put the slide. And I would like to, if anybody is interested in this book is the human factors method. It's about 600 page, very comprehensive book, which addresses about the 9 methods, and each method has about 12, 15 ways, techniques to address that. So I would like to highlight 1, 2, 3 things which is more applicable for space domain and also for hospital domain, medical domain. That is one is human error identification and HRA techniques. Another one is mental workload assessment techniques. It is. If you take human error identification techniques, there itself about 15 methods are there. Starting from the SERPA, that is systematic human error reduction and human error template. So each method has many plus minus things. So we have to see which context this method is suitable for us. I mean, our context we have to match and you have to take that it is. These are the 5 methods. So very interestingly in the book, this is one example given the book for the first method, SERPA, systematic human error reduction and prediction approach. He has given an example of the insulin task. So first they are telling what is the task analysis, total thing is given. And each step of the task is to be clearly, in fact, morning it was then our time index you have put like this, similar to that. Things. So you have put all the tasks clearly identify step by step, and you identify a set of possible errors. It can be action error, it can be checking error, it can be retrieval, all the errors. And each step you identify what are the possible error modes and what is the possible consequence, description consequences, then recovery, and what is the probability, whether it's low probability or medium or high, and you see the consequences. Then you find out the remedy, and how it is going to help is this remedy should be implemented in the design of the improvement of the system it is. So another one important thing which I find is more relevant is mental workload assessment. This also there are a lot of methods are there. I would like to highlight, we are following this NASA TLX and another method, modified Cooper-Harper scale. It is. Sorry. These are the methods, about 15 methods are there, 15, 17 methods are there. See, actually this Cooper-Harper scale I find it's very promising and it can be, I will highlight 1 or 2 literature which is already done in the medical domain also. There, okay. Basically this 1969 they started this method. So pilots, there are test pilots will be asked to evaluate the systems, aircraft systems, because test pilots are like a benchmark human beings. They go and test, they have to clear that. So they will be evaluate the thing and they will grade the system level 1 to 10. And it is always better to have level 1 to 5 system only. So the later 1978 onwards, they started applying for these various things, corollary of this. That is like mental, measure of the mental workload of the thing and measure of handling qualities. Basically, it is usability, accessibility and improvement possibility. All these 3 things are addressed it is. So this is another thing, very interestingly, it can be, we are applying this for our astronauts mental workload. This can be there. And here you can see there is this workload, mental workload of ICU nurses with a questionnaire survey. The NASA TLX, what is one of the methods they put? They have done. This I was quite impressed because before I came and present this, I thought whether I am going to talk relevant thing. Then I went into literature research. I am finding very interesting purpose which I was going to say it is being already done elsewhere it is. See all this method is a human factors and error prevention. In 2011 they have done. This is a general thing. And human error in emergency medicine. This is also 1998 itself was done. So all these things are literature. So it shows that these human error methods are having provisions there. Okay. Okay. With that, I will go to the next. So one point I conveyed is human error techniques and human mental workload assessment is one of the good things we can think of. Another one is risk management. It's a PRA method. Generally, I think some of you who worked on that, you might have heard about the FMECA in the medical domain and HASOB, all those things. These are all the traditional methods. Now, what is being proposed is a PRA, probabilistic risk. It's a very quantitative and more probabilistic method. Okay. See, normally what we take is in any system we develop, we find about we worry about the which is going to be high consequence in say event, which event leads to more catastrophic, and there may be events like which is high probability, low consequence. So we neglect that in any system design. But when it happens, two things together, that is high consequence, high probability, low consequence, 2-3 things simultaneously, similarly thing. I can give example, jumping the signal. We always do that. We think that I am going to jump, nothing will happen to me. The other person also thinks like that. When he comes, then there is a accident happen. So it is high consequence, low probability, high probability, low consequence as far as I am concerned. Another person also thinks low consequence, but when they come and meet, there is an accident happens. So that's why when you take the risk, it is a function of likelihood and consequence, a catastrophic. So how much likelihood? Normally all designs will concentrate on the low probability and high consequence. But when high consequence and low probability, we neglect. So, but when 2-3 events together happen, what is the consequence? That is the concept now they are using is scenario development, failure scenario. Don't address the failure event, address the failure scenario. Failure event is only one event. Failure scenario is many events together it is. And you see all the accidents, major catastrophic things are failure scenarios only. It's not a failure. And normally, so far we have been thinking any accident happens, we find the root cause and we leave it. But root cause is only, as I put it shown in the cheese model, root cause is only one. There are many defensive layers where the flaw is aligned. That is. So this PRA is one method. Okay. When you implement PRA, basically 3 questions are asked. What can go wrong? How frequently does it happen? What are the consequences? I am not going into details of these things. We are using the FTA. And this is a very big topic. I need at least 1 hour to give you a reasonable information on this. Only I want to give the flavor on that. Okay, this one micro example I have taken to explain how the PRA will be useful. When I say top event, it is undesired event, unwanted event. Okay, for the hospital thing, if you say wrong treatment started, that can be a one top event. That can be, we can first model it. It can happen because of the thing. Suppose A, E, F are the 3 events. So this A, E, F can lead to a stop event through this way. Okay, we can everything we can model through and R. It is going. Now, if you see this thing by looking at that, we will say when it will happen. If A fails, if A is occurring, it may occur. A, E. So these are 5 possible ways it can fail. Now, I don't want that event to happen. This event I don't want to happen. So then what I say immediately will tell we will improve A, E, F all will improve reliability. Then it will not happen. But the question is whether it is necessary, because resources management are important. We have to address clearly what really plays the crucial role on this. So this is when you take this system, every system can be put in the AND/OR combination and you use the Boolean arithmetic and you reduce that. So when you reduce this system is equivalent of reduced system of this. So now I need not worry about this, only I have to worry about this system only. So this reduces, it says A and E only. It says if A and E is working, this will not happen. I need not bother about F. It can be clearly it is entity also because E or F is there. If F is not working also, E is working, it's no use for me. So now as a resource manager, as a risk management manager, I will be concentrating on only A and E it is. So here we are saying the failure scenario is only 2 possible scenarios, A and E. I need not worry about that. So this is the way you have to identify the failure scenario and manage it. And being micro example, I told mathematically, it cannot be done when it's going for big exam, complex systems. So there are systems available or this software is available and we are doing that and it gives the probability of occurring also. So for example, this is the I was telling this is to be deboosted and coming back and parachute has to open and come and land with a less velocity. We have taken a simple case of this failure of this. What will do the failure of this parachutes, 3 parachutes? It is 3-level separation. If 3, what are the failures possible? We are done. So when you are done, instead of 3, there we read only 3, A, E, F. Here 222 basic events are there. And it gives me 12,568 failure scenarios. Now it is my responsibility to go into 12,560 and what is the probability of each one and what causes that, how to think. So this is the way the risk management is done and we are adapting this methodology. Okay, then we can say that a PRA, once you do this, You have to go, if it is not acceptable, until that you have to improve the design. Oh, here also I would like to highlight that this PRA already, they are, okay, patient safety improvement, the study is done. This is reported in the literature. PRA study is done. And risk management to EMS, the risk assessment and emergency process. These are the things. So risk management using PRA is one of the things. Okay, with that I think I convey two things. One is human factor methods are efficient in preventing and mitigating human-related errors in human-associated systems. Then PRA method is very effective in identifying the failure scenarios and reducing the residual risk remaining in the system. With that, okay, thank you. Thank you. Any questions? Okay, it's not there. Thank you. Thank you.
Thank you
Anyway,
very much.
Anyway, I want to thank Chairman ISRO, Dr. Brinda, and Dr. Alex and organizers for giving me the chance. Okay, thank you.
Thank you, Dr. Krishnan. Thank you very much, sir, for that wonderful presentation. Two important announcements. One is we are forced to cut down on the lunch time from 1 hour to half an hour. We will reassemble at 2 o'clock here after having lunch. And the second most important thing is the tag that has been given to each one of us has to be returned compulsorily before we leave the ISRO premises. That is the ISRO gate. We have to hand over. It so happened in the previous meeting, two very important people, by mistake, they sort of took away the tags, and we had to send somebody to their office and get to the hospital and get the tags back. So we only hope that some such instances will not happen. Let's all return the tags to the security at the ISRO. Yes? Yeah, food is being served at the basement. In the basement, it has been arranged. Kindly proceed to the basement and reassemble at exactly 2 o'clock. Please. Thank you. Thank you very much.